It's now 4 minutes after 8. This is Morning Express. And well, today being Wednesday, we're going to be looking at your health. Now, we do know that October is Breast Cancer Awareness Month. And as a result, we've put our efforts to ensure that we get as much information regarding cancer. As we all know, it has become a global concern, especially the numbers that cancer is literally. CEO for KMTC. Thank you for joining us, sir. We are also joined again by Joe Kiboy, who is a caregiver or who has experience in caregiving. He has the experience. So, gentlemen, thank you for joining us this morning. Let me start with you, Professor. KMTC, is there a specific course that is being given towards caregivers for cancer?
Thank you very much. Before I give the specifics, I think it's very important to note that all our programs has a component in terms of cancer. But we have now a very specific course, which is a higher diploma in oncology. That basically deals with cancer.
Okay.
And this is offered to nurses and clinical officers who have done at least whom they have a diploma first as their basic training, and then now they can progress and do a higher diploma in oncology.
Okay, so just to get this clear, when you say that there's a diploma offered specifically in oncology, this is just to deal with all types of cancers, not a specific?
No specific one,
okay.
all the cancers.
All the cancers.
Yes.
All right, has this diploma been there for long?
Not for long.
Okay.
It's a new program because we develop our programs based on need. When there are changes, for instance, now there's a lot of issues to do with cancer. We have also has components of cancer. But that one does not go into deep issues on cancer as the higher diploma in oncology.
Okay. Coming to you, Joe, I know we had your story previously, but for the benefit of somebody who may not have heard it, briefly, just tell us what your story is in terms of caregiving.
I was a caregiver. First, let me say thank you for having me here for the second time.
Right.
I was a caregiver to my wife, who unfortunately at the end of it passed away. And that is when I came into the role of caregiving. It was a completely new thing to me, you know. I mean, it's something I got into and took all of my time. I dropped everything that I was doing, my businesses and everything.
To take care of her.
Now, coming to such a role is completely a new thing because the expectations are not what you expect.
On the ground.
The support is not there. Most I'm surprised that now we are doing, you know, the KMTC is doing caregiving, because the first thing you come to find out is that when you are handling a sick flow of information, to get the information to know what is wrong with your patient, the processes that they use to get to, you know, to diagnose your patient. So it's a harrowing experience.
It's a harrowing experience.
Yes, it's a harrowing experience.
I'll come back to you on some of the things you possibly wish you knew at the beginning that would have helped you either as a caregiver or would have helped your wife, you know, at least be a bit more comfortable. But coming to you, Professor, I assume that, like you said, some of your courses are driven by demand. Obviously, this is out of the demand that we have now. But if somebody wanted to embark on that course, do they start on it immediately on oncology, or do you do a general course, then specialize?
The approach we have taken on that course program on oncology, the first area gives, because what happens is that you must have done a diploma, which gives you the basics in terms of cancers generally.
Right.
So you already have the basics in terms of the biology, in terms of the cancers, what are the causes, and so on. So that gives you now the framework to be able now to come in and do the higher diploma, which now zeroes in on all the cancers, but with the details that are required. That's the requirement for you to...
That's the requirement. And this is a course that, what has been the uptake? What has been...
As a country, we are really looking at people dying from cancer. And we have seen in the last couple of months, prominent people. And I think that's the time it has really come out, being highlighted that cancer is a problem. But I can tell you it has been there. It's only that a few of the prominent people have gone. But we have all lost either friends or relatives whom you are aware. And the demand in terms of numbers, we are not even able to take everybody on board at the same time.
Right.
Because we have also to look at the facilities that are required. There are few hospitals which have the capacity. And for us to be able to train these people, they must get practicums, which we look at mostly the level 5 and level 6 facilities, because we work closely with the hospitals. As we give the theory, they need also the practicums, which are actually based in the public facilities, and mostly is in level 5 and level 6.
All right. Mr. Kiboi, what are some of the things that now with hindsight, with the benefit of hindsight, you wish you knew at the point where you began now giving care to your wife?
That's a very good question, Mike, because today I have realized that you cannot caregive alone. You need a lot of support. And I came across a group that is called the MAU, okay, who they have caregivers, cancer patients, and nurses. Okay, a lot of Kenyans, I must say, Gitonga, do not understand the purpose of a hospice. When I realized that the purpose of a hospice, which I work in one, I manage one, is that when you have cases like cancer, where we don't see, you don't heal in cancer, you regress, your cancer regresses. Therefore, it's a long-term care. Therefore, when you have a hospice, especially in your area, you can engage a hospice which has qualified people who can be taking care of, can assist you in taking care of your patients. Now, that means as a layperson who has no medical background, you need the palliative. There are two ways of taking care of a patient from a hospice. There's a hospice case and there's a palliative case. Hospice case is people, let's say, who have diseases that are not terminal.
Right.
Palliative care is people who have diseases that are terminal and have a specific timeline to live.
That you're working with.
Yes. Now, when you come to cancer, the demand for it, the caregiving stress that would be alive, I believe, and a lot of other people would be alive.
What would you have done differently?
One, the aftercare after chemo. Okay, most of the cancer patients, the biggest thing, and I think I said the last time, what really kills them is the after effect. After the
chemo,
after chemotherapy, you get a lot of opportunistic infections that come in. Now, most people don't know how to take care of these infections. Okay, and getting to hospital is also a big problem. Therefore, if you have people within a hospice within you, because you will not access doctors all the time. I had a problem accessing my doctor because every time I call them, they would either be busy somewhere else.
They're scarce.
Their phones are off. And that's stress. But when you come over and see that you have hospices who have caregivers, these people are available to you all the time. Any time of the night, any time of the day.
On now the training of these caregivers, does it encompass the preventative aspect, or at least, because there's the care there's different kinds of care when we talk about cancer. There's what can predispose us, because I think it's still a debate out there as to what causes cancer. That may not have been finalized, but there are things that are possibly predisposing. So does this caregiving encompass that part, preventative, rather than just when you have already been diagnosed with cancer?
Thank you very much. I think in terms of cancer, the first thing that we need to do is to start with prevention. And all these programs that I've mentioned gives an indication on what are the preventive measures that are required to be taken into consideration. One is that we need to carry out diagnosis very early in order to manage cancers. The unfortunate scenario is that most of the cancers are diagnosed when it's very late. And we have our own program which deals with health promotion as a component of prevention. And that goes all the way to the community level. And as I mentioned earlier, all our graduates must do community service. And when they carry out that as part of their training, they look at, rightly said, is that the causes are several. We have genetic causes. We can talk of environmental causes. And these are basically carcinogenics. And when you look at the carcinogenics, it depends on what kind of exposure you get into, apart from the genetic component. Because if you look at some of the cancers, it has been associated with genetic predisposition.
Right.
But at the moment, we have other things that we can prevent, lifestyle, the food that we take. You look at issues to do with alcohol consumption, smoking. Those are factors that
can predispose
you. And those are things that can be prevented. Yes.
All right. Joe, by your experience, you probably would qualify as a trainer of sorts, even if you've not gone through the formal education system of how to train. But I'm sure from your experience, you would train. What are some of the things that you would want caregivers, particularly those who may not have gone to KMTC to train for that, to know? Because this seems to be something that we, by virtue of our culture and how we are socialized, when we have a terminally ill person within the family, the natural thing we do is get a relative to come and take care of them, as opposed to, you know, hiring a nurse or getting somebody who has that information. What information or
a patient, most of the time it's somebody who's very close to you. Now, the things that come to you as a caregiver are varied. First, you need to know you're concerned about the finances for treatment for this patient.
Right.
That is one. Two, you're concerned about their general well-being. Are they eating well? What is their psychological what is their psychological status? There's so many things that you cannot be able to come over as a person who has just come into caregiving and say that you can give any broad-based advice. The best advice I can tell caregivers is that let them not do it alone. Let them get other people to help them. Be able to take breaks, because you find most caregivers, they don't sleep. They don't take care of themselves. They have a lot of psychological and mental stress that they completely discard themselves. Because one, you don't sleep because your patient needs your services throughout, even late into the night. Your eating habits, they fall, you lack appetite, you're stressed, and most of all, the concern for your patients. So ideally, the best thing is to get other people.
There are several aspects when it comes to caregiving that, of course, we need to look at. Mainly, I think we tend to concentrate on the medical and the physical, because that's what we can see, because that's what needs to be dealt with. But there's an area that we seldom discuss, and that's the emotional. Does this caregiving training that you give look at the emotional aspect of it? What Joe is mentioning here is an emotional drain that sometimes comes on the person when you see a patient who's deteriorating or who is suffering.
Thank you very much. When you look at all the programs that we are offering, it has a component of psychology, which is basically you are looking at the emotional, because the first thing as a caregiver, you must be emotionally upright first to be able to manage, because there's a lot of psychological issues that comes around when you are managing people, especially with terminal cases. We provide the avenue so that they are trained to be able to handle that process. And remember that at the moment, training in medical is really a calling. If you don't have that passion and the calling, you must be able to do a lot of training and acceptance, because you can imagine if Tonga you're taken today.
Again, I'm just going to give the advice.
Because you give all your knowledge, give all your time. In most cases, as Joe has said, you'll find out that this nurse, whom even if you employ to come and take care of that patient, will be there 24/7. And that person needs a lot of emotional training and care to be able to handle the patient and also handle himself as he provides the care.
As he provides. I'll come back to you, especially on handling yourself, because we may concentrate so much on the patient and forget the person who's giving that care also requires some counseling and just preparation. Joe, the question of stigma, do you think stigma has now somehow been removed from cancer? Because there's a stigma that comes with it, that the minute you're diagnosed with cancer, there's a tendency for people to imagine, think, and feel that that is now almost
Cancer in the inside. Cancer in the inside is that I am normal, I'm talking to you, I have no physical wound. And therefore you do not, apart from being told that this person has cancer, that you cannot tell that they have cancer. Now there are some cancers that now come out. like when a woman goes through mastectomy and it goes wrong,
Right.
or they've not gone for treatment and the breast starts becoming a wound and it starts festering. When a woman when they have cervical cancer, now you find they're totally stigmatized from the home. First, the husband cannot stand a woman without a breast. So therefore, they do not want to see them around. In most cases, most women are actually abandoned.
Right.
Now, cervical cancer is another whole story because it's a very uncomfortable type of cancer that women actually start stinking. Now, you can imagine somebody in a house, they're stinking with the family. Nobody wants to see them. In some places, they're locked out into a different home. They're put in a different home and fed, from, in very, stigma is real. And that is why sometimes I talk to the government. I try or not talk to the government because sometimes you don't know, they are not there to talk to, right? That we really need to move to the next step and to recognize that we have human beings who are suffering. Because, and I'm sorry to say this, cancer is only brought out when we lose big people.
Right.
Okay? These big people have the money to go anywhere they want. Getonga, in the villages, these people have no access to facility, leave alone money to go to hospital. Go to Dandora. You'll find so many women and men who are sick of cancer. They can't even get fare to go to Kenyatta National Hospital. And yet we are saying we are treating cancer. Go to Lucy, it's called Madam Lucy Hospital. There are no facilities. Kenyatta has the facilities. But then again, what they lack is the human content.
Right.
Because some nurses are really rude. And I'm sorry to just you diagnose, somebody is diagnosed cancer, and here you are holding a file, and you're calling out, Mr. Gitonga, how are you here? We're going to cancer. Nendo kapeo chemotherapy. What kind of how are you breaking that news? Therefore, we need to be more human.
More humane.
Yes, the government is the biggest caregiver. Let them play that role.
All right, Prof, coming to you, one of the aspects that many nurses who would even want to enroll would be concerned about is also remuneration, because this is literally when you take up a cancer patient, there's no telling how long that is going to be, what kind of care they need, if it's 24/7, if it's maybe just several days. What advice do you give to nurses who would want to get into this space in terms of remuneration? Because government doesn't seem to be a very good payer so far.
I think, Kitonga, that's a very important area because all this caregiving, especially in medical, is a calling. So at the end of the day, the happiness that we get is the fact that you have been able to give care to somebody and change her life or his life, because that's the bottom line. Money, to me, comes second. Because the first thing is that these are human beings that you are handling. It may be you next time, because it doesn't mean that if you are a doctor or you are a nurse, you cannot get cancer. A number of our colleagues are also down with cancers and other diseases. So my advice is that, yes, let us get the basic that is required. And again, remember that we have gone through several systems. Like now, the employment is actually by the devolved units. For us as KMTC, our main mandate is actually to train. We don't employ. So basically that now leaves to the other arms of the government to handle that component.
All right, Joe, do you feel
concern? You cannot take care of somebody else if you have not
been taken care of yourself, right?
Okay. Therefore, I will, with all due respect, disagree with the professor and say that caregiving is a calling. It's a job. When I become a nurse and I say I want to become a nurse, I'm going to work. We cannot say that everybody has a calling. Therefore, we won't have enough. Therefore, first and foremost, take care of these people. Pay them well. The MPs are paying themselves well. Why don't they pay people who are actually doing the proper jobs well? So first and foremost, pay our nurses well. When you have paid the nurses and doctors well, and you have given them the facilities to be able to work, this country is going to be a good place. We are going to have a happy working nation. We are going to have a productive nation. But you cannot, for heaven's sake, put health under all, of all priorities, that health is down there.
Of the nurses.
And the only way you can take care of the nurses is by paying them well. Pay them well. The money is there. I think the government is there. And I think it's Professor, as the head of KMTC, you are responsible. You should lobby with the government to pay. They are not maids, even though no disrespect to the to the house help, but they carry a bigger role.
It's a specialized care.
There are people who pay their house help more than the nurses. Why should that happen in this country? We have resources. They should.
They should. Yeah. Anything you'd like to maybe add on to that, Prof?
I think what I'll just add on that is that I agree with Joe. And I said the fact that caregiving is not an easy job. As we put it, yes, it's a way of earning a living, but it's a way also of giving service to the community. And that goes with the fact that if you look around, medical training, from the word, first you must internalize as a caregiver that, yes, I'm going today to work from 8 to whatever time. And I say there's no limit, because if you are taking care of somebody who is ill, then it means you have to be there 24/7. In fact, you not only need one, like Joe said earlier, you'll need a couple of people. You'll need a nurse, you'll need a psychologist to be able to take care of the patient and also the nurse herself or himself. So that combination of people, you'll need other specialists in that area. People will be, you need somebody who is specialist in terms of treatment, whether it is chemotherapy, whether it is radiology. You can think of surgery, you need a surgeon. So it's a combination of factors, a combination of individuals with all the specialties to be able to take care of that one person. But what is important at the moment is, I agree with Joe, what has happened is that probably we talked about prevention. And that's why now we are talking of primary health care. So that even in the remote areas, we should be able to diagnose most of the diseases immediately. There are new technologies now that have come into place. And I want just to mention something very small which Joe has touched on, stigma. I want to give you a scenario of HIV/AIDS. When it was first identified in this country, it was like a life sentence. Stigma, you look at Kitonga, you say, he may be suffering from HIV/AIDS, and people run away from you. But it's no longer a sentence to death. That stigma has been taken care of. The same with cancer. Stigma is still there, but it starts from me and you to accept.
All right, we'll need you forward, particularly to make the lives of those who are living with cancer more comfortable.
First, I think we need to create more awareness about cancer. Two, there are facilities that, even, just like you said, we need to recognize these facilities, let's say like hospices. Hospices also, they need to be put into an NHIF scheme. We need more caregiving nurses, palliative nurses taken out into the counties, because we just have, like it says, we have what we call curative nurses, treatment nurses. We need more on caregiving. There are girls and boys who are willing to do caregiving. The other day they were asking me, can the hospice provide us with caregiving, the training, just the basics, so that at least they can do basic caregiving, because it is not only going to be that they're going to help me, they're going to help the communities they come from. Then finally, I think Kenyans also need to take care of themselves. Let them not be rushing to do something because it has happened. And I say this because we have hospices, and make sure they are equipped, they have the proper staffing, and they have everything, because the communities, the immediate communities who do not have the money to come to the Nairobi hospitals and the whatever, will access those.
Look into prevention. And as KMTC, we provide opportunities to train not only the professionals, but we also have short courses in various aspects. And we also take a role in terms of medical camps. We have a very good working relationship with Beyond Zero, where we carry out diagnosis as early as possible. What I'll urge Kenyans is that they should come diagnose when it's too late. And I agree with Joe that we must take our health as individuals first. Because in most cases, we know the information is available, but how many of us go even when their medical camps, free medical camps for checkups? You find people don't go. They don't. They think that probably if they are told they have cancer, they have HIV/AIDS, they have other diseases, and then it's a death sentence, which is not. And I think we need to create more awareness. Kenyans are enlightened. It's only that we need to take that in the Big Four agenda, the UHC, and now looking into primary health care and that referral systems. Of course, we'll now have people working in the communities, and they'll be able to identify these diseases early and give those referral systems. And the national referral systems are now cascading down. And I can give an example where we have the cancer center which has been established in Bomet. MTRH, they went there and trained the people on the ground so that that pressure reduces.
It reduces
at the
on the
level.
national level.
So I want to encourage Kenyans that let us take health as a priority as individuals so that we get information early enough.
All right, thank you very much, Professor Mike. Breast Cancer Awareness Month. It's now 25 minutes to 9. We take a short break. When we come back, let's look at what's making headlines internationally.